If we shorten the number of work hours that a given resident spends, someone has got to be there to provide that care.
It's to the advantage of both the physician in education and training as well as to the patient if continuity of care is scrupulously adhered to.
The only option that is going to cost less or will not cost more is if you do away with the house staff program altogether.
The American Medical Association presents an AMA teleconference, Cost of Resident Physician Work Hour Regulations, Rhetoric versus Reality. Extremely long hours are an expected part of their training. Some believe this tradition is a rite of passage that tests a physician's worthiness. Still others claim that long hours are essential to proper training, stressing the importance of continuity of care. And others believe that residents are just a source of cheap labor. In 1984, the tragic death of a young New York woman first brought attention to the issue of residency hours. In the case of Libby Zion, the grand jury returned no criminal indictments against New York Hospital or its physicians, but found much fault with the present system of residency training and physician supervision. The grand jury report was, in effect, an indictment of U.S. graduate medical education. It noted that both the intern and resident attending to Libby Zion's case had been at work 18 hours when she was admitted. The grand jury recommended that regulations be promulgated to limit consecutive hours for residents. It also noted that in the Zion case, an attending physician had not been present. The grand jury recommended that all emergency rooms be staffed with physicians who have completed at least 3 years of training in emergency medicine, and that residents be supervised in person by an attending physician. In October of 1987, the New York State Ad Hoc Advisory Committee on Emergency Services issued its report on supervision and resident physician working conditions. The report recommended that residents and attending physicians work not more than 12 consecutive hours per rotation in emergency services. The committee also recommended that a resident's scheduled work week not exceed an average of 80 hours per week over a 4-week period, and that residents must be given 24 consecutive hours off every week. The New York Department of Health adopted regulations that encompassed the committee's recommendations.
Well, first I'd have to say that I think that many of the reforms in the code are something that we welcome. I think the reduction in stress and work hours that have been proposed for house officers I think will be beneficial to patient care and to the educational process. I think further the stipulations that there should be adequate ancillary help so the physicians in training are not doing the things that one would expect other people could do and reduce the amount of non-educational time and non-service time that the house staff have to spend.
In this whole equation, one of the most important things in my judgment is the quality of life of the resident himself or herself. And I would submit that when we make any changes with respect to the quality of care and the quality of the training, that we ought to also pay attention to the quality of life for the resident.
In addition to New York, other states, including Pennsylvania, Massachusetts, and Missouri, are considering regulations to restrict the hours residents may work, and still other states are either studying or discussing the issue. Although the new regulations are important to improving patient care and residency training, they will mean increased hospital costs.
If we shorten the number of work hours that a given resident spends, someone has got to be there to provide that care. That means that we have to either have more residents or we have to have more participation by supervising staff. Now, if we do that, that is going to mean more involvement by more people, and that drives up costs.
The other concern that all of us have is that even if this money were available to us as program directors, where would we get the attending physicians, where would we get the nurses, where would we get the IV teams, the phlebotomists, the attending physicians that are necessary to make this program work.
Since the New York regulations were adopted, many reforms in graduate medical education have been discussed. Residency review committees have taken a careful look at training programs. Today, many feel that the profession itself should be allowed to make the necessary changes in training.
It may end up that the people who are in unions and other less organized with organized medicine positions will get their way, that is legislation. And what it would take to get there is for the organized medicine entities, especially the ACGME, to fail to find a solution to the problem. If we can't convince legislatures through ACGME and RRC changes that we're making an effort to implement those changes, then the legislatures will take it under their own purview. Probably the only thing blocking them now is that the ACGME and RRCs are attempting to make those changes. It may be that the financial disincentives and costs are going to further influence what the legislatures can do, but we'll have to wait and see. It may well be that the legislatures will finally decide that money is not the ultimate determinant of medical and health care. If that's the case, then I think they're going to make changes that the ACGME and RRC failed to make.
Hello, I'm Joan Esposito. Welcome to our teleconference on work hour regulations and their cost implications. Over the past few years, there's been much rhetoric concerning the complex issues of graduate medical education and the number of hours residents should work. However, with the recent adoption of regulations in New York State, a new reality has been taking shape. Today we will discuss the major issues related to work hour regulations. We are coming to you live from the Chicago Hilton and Towers, where over 200 resident physicians have been attending the annual meeting of the AMA Resident Physicians Section. Joining me for today's discussion are Elizabeth Summers, Vice President of Regulatory and Professional Affairs at Greater New York Hospital Association; Dr. Timothy Deaconson, Department of Surgery, the Medical College of Wisconsin. Dr. Deaconson, by the way, was first author of the controversial report on sleep deprivation and resident performance that was published in the Journal of the American Medical Association in 1988. Bertrand Bell, Dr. Bertrand Bell, chairman of the former Ad Hoc Advisory Committee on Emergency Services. That was the committee appointed by the governor of New York State. And Dr. J. Dockery, chairman of the Accreditation Council for Graduate Medical Education Task Force on Resident Physician Supervision, and also chairman of the AMA Council on Medical Education. Dr. Dockery, if I could start with you, can you tell us, first of all, simply what is the Accreditation Council for Graduate Medical Education, and what sort of ideas have they formulated?
Thank you. The Accreditation Council on Graduate Medical Education is a body that maintains the standards for accreditation and is composed of 5 parents consisting of the American Medical Association, the American Hospital Association, the Association of American Medical Colleges, the Council of Medical Specialty Societies, and the American Board of Medical Specialties. Plus we have public representation, governmental representation, and a representative from the resident physician section. As a result of the interest in resident supervision and resident working hours, the Accreditation Council on Graduate Medical Education established a task force in June of 1987 to develop a report on resident working hours and resident supervision. We completed our report and recommended to the Accreditation Council on Graduate Medical Education that we request all of the residency review committees of the 24 specialties that are represented in the Accreditation Council on Graduate Medical Education to develop guidelines and the general requirements and special requirements for accreditation that would define resident supervision and resident working hours.
Speaking for the AMA, can you tell me, Dr. Dockery, what is the AMA's position at this moment on the number of hours that residents should work?
The American Medical Association and the Accreditation Council on Graduate Medical Education have decided that it should be an individual specialty decision concerning the conditions and resident working hours. Because of the difficulties in medicine and because of the difference in intensity between specialties, it is not felt that it is best to establish a time clock under which all residents should work and function. The Accreditation Council on Graduate Medical Education, as well as the Council on Medical Education, develop guidelines as recommendations, as suggestions of a quality kind of resident working schedule that would involve every third night off and every day out of 7 that would be away from the hospital. That would be roughly an average of about 80 hours a week, but it is not a fixed schedule that would provide the level of intensity to be operative and at the same time to provide the continuity of care that is desirable.
As we saw just a moment ago in the videotape, the Libby Zion case was instrumental in stimulating this discussion about changing the regulations. Dr. Bell, I know that you recently met Libby Zion's father when you were on a talk show together. What did you say to him about the changes forthcoming in graduate medical education?
Well, first of all, I don't think that the concept of a time clock fits into the practice of medicine, and I think it's very important for people to understand that. I also think that what we're talking about are schedules. We are not talking about continuity of care per se. We're talking about setting up schedules which will allow people to fulfill their commitment to patients. I think that the most striking thing in speaking with Mr. Zion was I became aware of the fact that I was talking to a father and not to an attorney or to someone who knew the media, but talking to a father who had lost a child. And most of the discussion with Mr. Zion put me in the role that I'm familiar with, and that was of doing what I could to listen to him in his anguish, which is still there 5 years later.
Dr. Deaconson, you were one of the primary authors of the study that boiled down to an inaccurate generalization, said that doctors seem to be able to perform well even after 12 hours, 24 hours. They seem to be able to maintain a high level of performance. Regardless of that, what about the public perception that doctors who are tired may not give me as good a care as doctors who've only been on duty 5 hours or 10 hours instead of 24 hours or 30 hours? How do you deal with the public perception regardless of what the scientific study shows?
Well, I think that the public perception should be divided into 2 categories. There's the well public and the sick public. And as a primary practitioner of general surgery, I know from experience that the sick public frequently wishes his or her own surgeon or internist to be available at all hours of the day. Many of us have heard anecdotally women complaining when their own obstetrician is not on the night that their baby is delivered, complains that they're not there. But then there's the well public's perception, and that is basically generated by the media. To the well public, the media is the interface between medical practice, resident and student training, and the public's perception. To get more specific on our study, we are simply stating that in our study, we did not find detectable sleep deprivation-induced impairment. Now, we realize these results may not be popular, but out of scientific honesty and responsibility, we had to report them, and in no way wish to play the politician and pose a threat to residency training reform.
You say the media is responsible for the public perception. Are you saying that because of what they see on television or what they read in the papers, that's what's going to make a person think that if their doctor has been up for 36 hours straight, he might be fatigued?
I'm simply saying that the media is an interface. Different people react to stresses, one of which is sleep deprivation, in different manners. And I think we are remiss and guilty of oversimplification if we say that a time clock, as Dr. Bell said, is a simple definition of a physician's capability or not. We simply state in our article that we did not find, after 24 hours of work, a detectable level of impairment.
What do you think the average layperson does think about that, if indeed they think about it at all?
That's a hard question. I'm not an average layperson, nor any of my family, having endured 6 years of residency with me. So I'll have to defer on that question, perhaps to someone on the panel who's more representative of the lay public.
Before we continue with our questioning, I'd like to let you know that there's an 800 number. Those of you who are viewing this teleconference from around the country can call in with your questions. The number is 1-800-227-7903. We'll be putting that number up on the screen, and I also want those of you who are in the audience to know that you can begin lining up at the microphones if you also have questions. You see they're numbered 1, 2, and 3, and I will be calling questions from the various microphones. So if you have questions, feel free to begin to line up. But for now, I'd like to go back to our panel. Ms. Summers, based on your experience in New York, which of course, as we just saw a moment ago, has begun to adopt regulations, what advice would you give to these residents if they come from a state whose legislature is taking up this issue for the first time?
I think the first thing I would say is to get involved, for every resident to try to understand what the proposals are and what the implications are for them. And not just the PGY 5s, 6s, 7s, and 8s, who apparently, in our state anyway, were somewhat more involved, but at every level, from PGY 1 and above. We at the association that I work for did a study of the original recommendations of the, what we fondly call the Bell Committee, and we involved only the chief residents, and we were sorely criticized for doing so because we were accused of asking those people about working hours who could no longer remember what it was like to work that hard. So in deference to that criticism, I offer to others who are going through the process the idea that everyone from a PGY 1 and above should get involved. And residents shouldn't allow one or more small organized groups to speak for them as a whole. In New York State, we had one very well-organized group which does not represent the majority of the residents, but were very articulate, vocal, and involved. And it is perhaps due to some of their more persuasive efforts that some of the regulations went through in a very rigid manner. My other suggestion would be to take what's proposed and throw it up against what you currently do, and look at other alternatives that may be acceptable. Sometimes things that sound good on paper don't work out as well when you have to actually put them in place. I think in New York we're looking at a situation where we may end up with some schedules that are really not what anyone anticipated in order to cover gaps that are made by changing working hours rigidly. So my suggestion overall is to get involved very early on and become part of the public process.
Give us your assessment. How is it going in New York? Is it untenable? Is it too expensive? Is it working?
Well, it isn't working yet. It doesn't really actually have to work until July 1st, but I think it's fair to say that there are very few programs that anyone knows of that will be in complete compliance by July 1st. One of the reasons is that, and I checked today back in New York, as of today, no voluntary not-for-profit hospital in New York has any idea how many people it's approved to hire or how much money it's going to get to implement these things. People may say, well, but you've known about this for a year. Yes, we've known that these regulations were coming down the pike, but individual institutions have been unable to make commitments to people because they don't know whether or not their plans for compliance are approvable and therefore reimbursable. All I can say is there are a lot of creative strategizing sessions going on around town, but my guess is that in New York anyway, while we're making a good faith attempt, we will not be in compliance come July 1st.
Thank you very much. We have a question in the audience at microphone 2. Before you ask us your question, could you tell us who you are and where you're from?
Yes, I'm Howard Epstein, and I'm from Massachusetts. I'd like to address my questions to Dr. Dickinson about the study. I'd like you to comment a little bit about your study, specifically about the significance of the differences that you found between your control group and your test group. Specifically, I would like you to address the question of whether there was any real difference between the level of fatigue of the people who were tested as the control group and the people who were tested as the test group. One, in terms of the control itself, and two, in terms of the bias. Let me explain my question briefly. First of all, in terms of the control group, can you demonstrate that the people who were tested or who were labeled as the control group and the people who were the test group weren't starting off already fatigued? In other words, you were taking groups who were in a general surgery rotation, and I'm wondering if the people who were tested as the control group had some sort of vacation before so that they weren't chronically fatigued. But then also within the study itself, I seem to recall a level of sleep activity or off-call activity of 4 hours. And I'm just wondering how you could demonstrate a real difference between somebody who had, say, 3 hours of sleep versus somebody who had 4 hours and 10 minutes of sleep. And then also, after you address that, I would like you to address the issue of how your study was impartial or how it was blinded. In other words, it seemed to me, reading the study, that residents knew what category they were in, had some sort of peer pressure associated with that, and how that affected the impartiality of your results and therefore their scientific validity.
It was a series of 4 questions and a couple political statements, but I'll answer the questions. How about that? First, I'd like to take the opportunity. I understand our study was controversial, and I expect to field a lot of questions. Some of the editors of JAMA have told us that our article has generated more letters of response than any study that they can remember publishing. I will say that after they screened these letters, I received over 200 of them after screening. The majority of questions are answered in the manuscript, and if anyone is going to ask me a question about rhetoric or method, please make it a pertinent question. Many of these questions are answered in the manuscript if you read the manuscript in whole. Okay, question number 1, chronic fatigue. Basically, you're saying we're our control people, and each person was his own control, so that control people is not an accurate statement. Were they chronically fatigued, and were we simply comparing chronically fatigued people with a night's rest versus chronically fatigued people with a night's work? That's your answer, or your question. My answer is Medical College of Wisconsin has a very unique call schedule system for the surgery residents, which I helped design in 1984. We have a trauma team which takes all the emergency and trauma admissions. Everybody else has no in-house call, and all admissions are to their services elective. Therefore, at the start of the study, when these residents who participated were beginning on the rotations that generated sleep deprivation, they were coming off of a month during which they had no in-house responsibilities. Okay? Second of all, to test this hypothesis of chronic fatigue mixed in with acute fatigue, we took the residents who individually had greater than 50% of their nights total represented as sleep-deprived nights, and we compared their overall absolute scores at the beginning of the month to those overall absolute scores at the end of the month, corrected for learning effect, and found that there was no difference. So I think we have concluded, even though that the number of residents is only 26, that the chronic fatigue, whatever the definition of chronic fatigue is, did not play an effect. 3 hours versus 4 hours. Well, when we first asked ourselves the question that we were going to answer with our study, we had to come up with some definitions because the body of knowledge on sleep deprivation on physician subjects is very small. We had to glean the definitions from the lay literature, the military literature, air traffic control studies, studies done by psychology departments on graduate students. We found that the 4-hour definition was the most recurrent. We analyzed our data for 3, 4, 5, and 6 hours. The 4-hour one was done prospectively in a blinded manner, and that's why it is that data that we presented in our paper. Obviously, we had to retrospectively assign 3, 5, and 6-hour definitions. We didn't find any significant difference there either. The next 2 questions deal with how well blinded were they and were there peer pressure effects. Well, you have to realize one thing about physicians. When you're testing physicians and motivation, ideally a physician, even when he is sleep deprived, is maximally motivated. I know this doesn't always occur, you and I both know that, but ideally he's maximally motivated and performing to the best of his ability. Now, can we influence an individual to perform beyond the best of his ability? No. So we merely tried to mimic that situation that would ideally occur in a clinical scenario by maximally motivating our residents to perform during the study, such that negative motivation would not create a self-fulfilling prophecy that would show a sleep deprivation effect that was in fact artificial because they knew it was a study and not a patient's life that was at stake.
Tim, since you've handled the first 4 questions, there's one other issue I want to raise before we move on. An issue that has arisen after all of this discussion is what happens to continuity of care, aside from all of the fatigue and other issues put aside. Now, Dr. Bell, as I understand it, even if there is a regulation put into effect that says a resident must only work 12 hours, there are not going to be work-hour police that charge into the hospital and drag that resident kicking and screaming home. Would you say that's accurate?
No, I think that that's very accurate, and I think that one of the things that's been surprising to me, the people who've talked about the so-called time clock mentality, that's not at all what was intended. What is intended is to have schedules made up that don't build in sleep deprivation and chronic fatigue. That does not mean that the commitment that every doctor is supposed to have to her patient or his patient is in any way changed. I can assure you that we expect, as part of being a doctor, that people are going to be there when they are needed and when they feel comfortable and feel that they're well enough to take care of the patient. Nobody's going to take care of a patient, hopefully, after they've been scheduled, we know to be scheduled. After 36 hours, people are not at their top form, and that's what we're talking about. We want to have schedules which are reasonable. We don't want to do anything. In fact, if we dare do anything with a commitment to patients, then we're not training doctors, and that's how we look at it.
Let's go to microphone number 1.
Thank you. My name is Dr. Mark Sobczak from Massachusetts, and I'd like to address the question of getting involved. I think a lot of us are here because we are getting involved in this issue, and I just want to ask if the first and second year residents are the people who you want to see more involvement from, with them typically working 120 and 130-hour work weeks, and often practicing or undergoing their training in a state other than where they grew up, where they may not be aware of the legislative differences. Where do you suggest that people find the time to get involved at this grassroots level that seems to be so important?
Elizabeth?
I don't know that I have the perfect answer, but I think one of the suggestions would be to use some of the morning teaching conferences on the part of the chief residents who have time to go out and learn about the changes, perhaps, and are not working 100 and 120 hours. I think if you go forward with a public position as representatives of a group, and you don't include the people who are what the public perceives to be those most affected, your position falls flat. You need to show their involvement, and whether you share it with them at morning rounds or conferences or canvass them by letter or whatever and show them the alternatives, you will not do well in the public arena, and we know that for a fact, if you don't have all of the forces marshaled from the PGY1 level up.
As a follow-on to that, you mentioned losing our believability in the public sector or in the public image. I wonder if we don't go forward either as the AMA or the resident physician section and take a lead on this, which is a question that obviously legislators and the public are becoming more and more aware of and more concerned of. Don't we, by default, lose our leadership role in that? And if we're not here to take that leadership role, what else are we doing here?
Well, I think you are here to take that leadership role. I don't know that I really understood the
Well, I'm just afraid.
difference.
I'm just afraid that if the things we do here, if we don't come forward either as the resident physician section or the AMA, and also recognize this problem that increasing medical technology and medical diagnostic procedures has caused, that we're going to lose the leadership role that we should be rising to at this point.
Yeah, I'm not suggesting that the position should be to balk at change. I think change is on the horizon. Whether any state legislature takes it on specifically, it is clearly coming everywhere. We are just the bellwether for the rest of the system. And I think you are obligated to present all sides, but I think what a resident physician organized group can do is show program differences and show where you need program flexibility.
We've got time in this segment to take one more question, and I hope it's just a one-part question. Microphone number 3.
Yeah, I'm Dr. David Bishai from Los Angeles, California. A question for Ms. Summers is what the impact has been on the New York training program's recruitment efforts. What's the applicant pool done?
Well, we've been having some trouble in the past anyway, for a variety of other reasons. New York is no one's favorite place to live anymore, apparently. But we have had some decline in internal medicine, and we had some trouble in pediatrics, but there are programs that specifically marketed the working hour changes and feel that their recruitment efforts were improved because they marketed those changes. We can only, obviously, as you know, increase residents in internal medicine and pediatrics to help to comply with the requirements. In the other programs, I don't believe there's been a substantive drop, although we have had trouble in psychiatry for many years. And one of the provisions of the regulations is going to make us somewhat more non-competitive. It will require PGY4s in psychiatry to be on call a significant amount of time. So we haven't noticed a precipitous drop, but it hasn't been an upswing in most areas.
Elizabeth, before we move on, Dr. Dockery wanted to make a quick comment on this.
Yes, it related to the previous speaker who asked how they could get involved, and I think the resident physician section of the American Medical Association should be very proud of their involvement in the manner in which they helped the Council on Medical Education develop the policy contained in Report C, which has adopted the interim meeting of 1987 and acted as a template and as instruction to the representatives of the AMA to the Accreditation Council on Graduate Medical Education that created modifications in the general requirements that improve the quality of life in terms of the sleep accommodations, eating facilities, transport services, phlebotomists, and other kinds of services that would relieve resident physicians from performing those duties and take away from their patient care responsibilities. Also, the resident physician is involved in the Accreditation Council on Graduate Medical Education and represents you very well.
One of the main arguments against regulation of resident work hours involves important continuity of care issues that we touched on briefly. Nowhere is this more evident than with the surgical program.
For practicing physicians and surgeons, as well as residents in training, continuity of care is one of the most important aspects of treatment. The current debate over resident hours challenges some fundamental characteristics of residency programs.
I believe the feeling of the college against regulation with specific hours has to do with the dominance of continuity of care in the care, particularly of surgical patients. It's to the advantage of both the physician in education and training as well as to the patient if continuity of care is scrupulously adhered to. Now, clearly, you can have 24-hour-a-day, 7-day-a-week continuity, but to the degree that it's possible, the focus should be on continuity of care rather than on arbitrary decisions that a 12-hour period in a given day or any of the other numbers that have been adduced should be adhered to.
For many surgeons, the reason continuity is such an important principle of surgical education is that in surgical care, decision-making is best learned and taught by continuously observing the course of a patient's illness or injury and the response to therapy for complex problems. Many surgeons believe it is the lack of familiarity with a patient and not fatigue which causes most errors in judgment.
So the whole ambulatory care concept poses difficulties both in continuity of care and also in teaching. However, the sicker the patient, this is not an absolute rule, but the sicker the patient, from the standpoint of both the patient and the individual who is learning as he or she takes care of the patient, the continuity of minute-to-minute changes and participating in those decisions and making those decisions is very important and cannot be learned except by being there on the job. And if you're in the midst of a critical situation when the time comes where you would nominally go off, it's been traditional, even though you had the time off or the evening off, that if a patient were critically ill, your own interest in that patient should dictate, as it did when you're subsequently in practice, that you want to continue to take care of that patient.
Recently, the Residency Review Committee for Internal Medicine released new rules that call for a maximum work week of 80 hours. The RRC rejected the 24-hour maximum per shift, citing concern for continuity of care. In addition, the RRC directed that residents spend 1 day per week away from the hospital on average, and that continuous emergency room duty should not exceed 12 hours. Other provisions are that residents not be on call more than once every third night, and that no first-year resident be responsible for more than 4 to 6 new admissions or for ongoing care of more than 8 to 12 patients per day. While many feel the new RRC regulations are necessary, enforcement must be made with a degree of flexibility.
One of the things that caused great misinterpretation is that
State regulations, and particularly in the states that have moved in this, such as New York, are characterized by their rigidity and non-flexibility. They, for example, say that 80 hours is 80 hours. It's not 81 or 82. And that averaging may not be the way to do that, and that one needs fixed time between periods of work. That is, limitation of 24 hours of work and a fixed 8-hour interval off, and that off is further defined as out of the building. Well, not all buildings in this country are the same. It's hard to know when you're in a building or out of a building or which building is a hospital. So I would say that the hallmark of the state codification and codes and regulations is rigidity, and I think what you'll find in the residency review committees is an attempt to comply, but adding flexibility that allows for education and good patient care.
You can call it a loophole, I'd call it flexibility. We'd like to have a residency training program director, or even the group of directors of a certain kind of residency, to be able to come to this organization and state a case. Here's a reason why we do not believe that we should have to comply with exactly the same rules as a dermatology residency has to comply with, for example.
When I first saw this videotape, there was one phrase particularly that caught my attention. It said that the new regulations would be imposed with, quote, a degree of flexibility. Dr. Bell, in the real world, what do you think that means?
Well, I think that everybody is very human and they want to do what's right. When you talk about flexibility, hopefully that's what you should be talking about. I suspect, though, listening to most of the people who talked about flexibility were people who in their heart of hearts thought that they didn't want to get this done, and one of the ways of beating it would be by using the term flexibility. And we spent a lot of time trying to decide. I'd like to remind people that the committee met for 19 months. There were a lot of people on it, and what we came up with we didn't think was particularly rigid. And so I would hope that people who are talking about flexibility are not talking about not carrying through with the necessary changes.
Dr. Dockery, speaking for the AMA, should the regulations be presented with a degree of flexibility? Does that mean hospitals will take advantage? Because certainly there seems to be an economic motivation to take advantage of the residents.
I think not. I think the present system that has been suggested protects the resident and the specialty and the profession from that advantage. The guidelines that have been distributed protects the resident environment. It established some guidelines concerning intensity of care. It established some suggestions concerning backup of care in the event that fatigue should occur with certain intensities of care. So I think there are a lot of safeties that are presented in the flexibility that will be safeties in the long run for the residents and also for the patients.
Elizabeth, go ahead.
Comment that we were, of course, in favor of flexibility within the regulations themselves. What makes us a little nervous in the hospital community is to have regulations that are in print flexibly enforced, which we consider to be an oxymoron. It's very difficult to flexibly enforce something because you have created a standard of practice. In essence, we have said that at the 25th hour, something happens, or at the 24th hour, something happens. Even if we flexibly enforce, in deference to the fact that we don't necessarily have the manpower resources on board to implement these rigidly, it would seem to me that others, particularly those in the legal profession, will have some advantage if a bad outcome occurs at the 25th hour after July 1st, in spite of flexible enforcement.
Before we go on, once again, I'd like to give out that 800 number. For those of you in our viewing audience, you can call toll-free 1-800-227-7903. And in this segment as well, we will be taking questions from the audience if anyone wants to ask a question or make a comment. And I think we have someone right now at microphone number 1.
My name is Bruce Dahlman. I'm a resident from the state of Illinois. We've heard continuity of care as a term bandied about. If you admit that residents need time to sleep, need time to eat, and would benefit from experiences outside of the hospital, there will always be breaks in the continuity of care. And that every moment in the course of a patient's illness, even if you're committed deeply to taking care of that patient, you will have to break away. you talked a little bit about standards of care. It seems to me we have a standard of care which is 36 hours, and we feel that somehow that's a magical number, that we aren't sure how we'll use a standard of care of 24 hours, but we have a standard of care of 36 hours. I guess my question is really, is continuity of care an issue that we are already dealing with in defining a shift with a certain number of hours? And it seems to me being used as a term to avoid addressing what we're really trying to do, which is provide a humane experience for a resident who's struggling to get an education. And I can't think of a single committed resident who would say, excuse me, my shift is up, I have to go now. And it's a little awkward that I hear that so often. Well, the schedule will be so clear-cut and there'll be a time clock that will go up. It seems to me you're lacking the commitment of residents to taking care of patients.
Anyone care to address that?
Yes, I would say bravo to what you said. I think that the continuity of care issue has just been thrown in by people maybe who aren't that close to residency training. People cannot provide continuity of care when they have been up for 36 hours. You can't get that kind of a commitment. And what happens when you have these kind of schedules is you begin to look at the patient as an enemy, and you start using pejorative terms like hits and gomers and so on, and you can't do continuity of care under those circumstances. So I think that what you said is 100% correct, and I think that's what we're trying to do. We're trying to make it so that what residency training really is graduate medical education, and I think a lot of people have forgotten that. You mentioned education. That's the first time it's been mentioned, and that's what residency education is. It's not service. It's service only to the extent that it's education, and that's the other direction we've got to move in.
Dr. Bell, these long hours have been described by some people as a rite of passage. How much of this whole issue is older physicians who've gone through it with the attitude, well, I did it, why can't they do it?
Are you telling me that I'm a young physician? I like that. But I don't think, I think that like with lots of things, we belong to probably the best guild in the world. We're doctors. And so older, fathers like to say, okay, sonny boy, you do it. But I don't think that's playing a big role in this at all. I really don't. I think that medicine is recognizing, and the ACGME is recognizing, that the thing that's important here is that we regulate ourselves, not the states and not anybody else, and that's the direction we're moving in. And I think that the lesson of New York State is if we do it, then we won't need anybody putting in inflexible or flexible or whatever kinds of rules.
Another question from the floor. Microphone number 3.
Hello, my name's Steve Panelitis. I'm a general surgery resident in Pennsylvania. I consider myself a bit of a minority because I'm in my second year and I have time to be here. That is mainly because I have a department head who he himself is involved with the AMA and wishes that his residents be involved. We are a regional trauma center and a large surgical program, yet we are on call every third night. For the most part, our residents are content where they are, and I certainly don't think quality of care suffers at all at our hospital. I have a question for Dr. Dockery. As I understand it, the AMA position on resident working hours is to more or less allow the various specialties to make their own regulations, and I would be worried that perhaps some of the specialties where it is needed most, like in surgery, may resist change, and they will not have change. Could you comment on that?
Yes, I think you would be reassured by the process in which the special requirements and general requirements go through. And to speak specifically for each specialty, they must be reviewed and approved for recommendation to the Accreditation Council on Graduate Medical Education by each individual parent of the ACGME. Also, at the time they're considered by the ACGME, they're discussed again by the Committee on Special Requirements, and there are always those modifications. So it's not that each specialty is going to be blanketly approved with whatever language they suggest, and we're very tentative to the descriptions of resident supervision and resident working hours. Now, I would concede to you that some of the special requirements have not been as specific, but in those cases in which they have not been as specific, they have inserted very friendly language for the first time that is an advocate for the conditions under which the residents are imposed to work.
Can we take the question at microphone number 2, please?
Sure. Thank you. John Klein, the resident member of the Council on Medical Education, also a pediatric trainee in North Carolina. And I wanted to address the issue of flexibility and comment and restate that question to the panel, if I could. The concern both with the Residency Review Committee's assessment of the work hours and supervision issue and the fact that those committees haven't been very inconsistent in their attention to the need for some reform, plus the fact that it's clear, as others have mentioned, that surgical programs and other subspecialties may be behind in responding to a perceived need for some change in these areas. I guess my question, to phrase it as a question, is how should medicine as the AMA or as the ACGME process, or how should the states begin to address specifically the fact that some specialties will not voluntarily comply with a flexible approach, much less a specific approach? And specifically, as we've seen when I was in Massachusetts with residents in surgery all being available at 2 o'clock in the afternoon to provide testimony, a curious occurrence that probably would not have happened were it not for the pressure from their training programs to be present at a state hearing. The fact that resident leadership in the resident section of the AMA who are in surgical training programs have had problems getting clearance to come to these meetings in the recent years since this issue has been on the forefront suggests that there is an organized response among some specialties to try and prevent this issue from moving forward. And in this, in the tone of addressing flexibility, how should medicine as a whole and the regulatory review process as a whole address that?
The Accreditation Council on Graduate Medical Education, when they made their recommendations, which was unanimously approved by the entire body, suggested that all residency review committees should complete their review of the special requirements by the end of June 1989. Almost all of those have complied with submitting their special requirements for review and approval. We have denied approval on some of those special requirements because they have not been as specific as has been desired. And in fact, in one case, it wasn't even mentioned, and it was referred back to that Residency Review Committee to react in the way in which they had been requested. There is safety in the process in that none of these special requirements have been implemented as yet. Many of them will be implemented July 1, 1989, and subsequent dates. The Residency Review Committee approval operations represent a delegated authority from the Accreditation Council on Graduate Medical Education to continue to accredit residency training programs in their specific specialty. The ACGME will continue to monitor their compliance with the modifications and special requirements, and if they're not adequate, then they will be modified.
One question that I would like to address to the residents, and perhaps John, since you seem to be already on the hot seat, you could handle it at least first off, is how much pressure is there on you to work 36 hours or longer? How comfortable would you feel, regardless of what regulations are in place, of saying, you know, boy, I'm really exhausted. Excuse me, guys, I think I have to go take a nap for a while. My understanding of the peer pressure in the world of medicine today is that most doctors would probably rather drop in their tracks before they said something like that.
Is my microphone on? Yes. I think that's a fair statement on your part there, and I think that it points out what the problem with this issue is, that people work schedules as established by their training programs, and very seldom will residents, either individually or collectively, speak to the problems with those schedules while they're working them or after they've worked them. And the reason, I believe, is because the primary commitment is towards patient care, and the primary commitment is towards making sure that our patients are being taken care of adequately. And in that sense, I differ very much with Dr. Bell. I think there's an essential service component to what house staff do, which is something that we need to continue to acknowledge in these settings. But I think that in addressing the schedules and then in addressing how we regulate or monitor these changes in training programs, that it's essential that house staff individually and collectively have an external mechanism for ensuring that adequate attention is paid to supervision and training issues. To expect residents, particularly in surgical fields where their future careers depend on next year's contracts in a system that already pyramids their training experiences, to expect them to appeal directly to their training program when their emotional or sleep or other needs are not being cared for is unrealistic. And in that sense, at the state level or at the Residence Review Committee level, we need to have an external and impartial mechanism for people to appeal these kinds of issues.
Thank you, John. Thanks for the answer and the candor. We've had someone who's waiting very patiently on the phone from Iowa City. I believe it's a resident there. What's your question, please?
Dr. Joyce, and I am a resident physician in Iowa City, Iowa. My question, it seems to me that the real problem with hospitals is that they've taken the Medicare dollars that were targeted for Medicare patients and they've allocated them throughout the hospital by having residents attend to Medicare patients as well as other patients. And my question is, shouldn't the third-party payers pay for the care that us residents are providing?
Dr. Dockery, you want to handle that one?
Yes, they in fact do pay, though it looks as if that may begin to disappear. A Medicare Part A reimbursement does reimburse hospitals for the educational component of the service aspects for the provision of care.
Watch out, I see Dr. Bell shaking his head there.
I think that's not quite accurate. What they pay for is patient mix, which is different than the educational component, and it's very technical, but I think that it's a mistake to let people think that Medicare is paying for education. What Medicare is paying for is for a patient mix that then involves certain kinds of educational programs, but I don't believe Medicare is paying directly for education, but it's a technical point.
Well, before we move on to other questions, I'd like to remind the audience that this teleconference is one example of how the American Medical Association continues to keep its members informed. It's all part of American Medical Association membership.
Let me pause briefly to recognize the men and women who've made this teleconference possible, our AMA members. Physicians, residents, and medical students working together to preserve the heritage and the future of our American healthcare system. Our members make a difference for you. Won't you join them now? We can do more together.
For more information, call toll-free 1-800-AMA-1452. In Illinois, call collect 312-645-4783.
As we continue, I'd like to take that same question I just asked John and turn it to Dr. Dockery. What about the peer pressure issues? What about a doctor being afraid to say that they've reached the fatigue point for fear of either letting their patient down or looking bad to the house staff?
Or letting themselves down, and I think that question is very real, and I think that John answered it very properly. I do think that we need to build in the recommendations that prevent the entrapment of the resident having to acknowledge, hey, I'm tired, I want to go. If we build in backup services for those people that are on duty for long periods of time that can relieve them, then they do not have to wrestle with their conscience and say, I can't take this anymore, or I can't handle this, I need to get away. If we build in a backup system, which has been recommended, and if the system will work in terms of short call, long call, and a variety of other mixtures, then we don't place the resident in that emotional sandwich. I would like also to respond to John's other question, which I didn't have time to do, and is it related to individual state regulations. I think the important initiative that the American Medical Association has taken and the Accreditation Council on Graduate Medical Education is to prevent the New York experience. because it's very damaging to those residents in New York if they end up not being able to participate in accredited residency training programs. It's going to impact on licensure, it's going to impact on mobility and the movement from one state to another, and there will be many, many outcomes that will be unfavorable to the quality of medical education, and I think that's our specific interest.
You don't really mean that, Dr. Dockery, because if you're telling me that the ACGME is going to disaccredit programs in New York State, and they're going to get away with a state that trains 13% of all the residents in the country, you're making a mistake. The ACGME is a voluntary agency. The state government and the federal government have agreed to recognize us as a voluntary agency, and the muscle is in the people who have the money and are doing the paying, and that's the government. And I don't think that the ACGME had better even think about disaccrediting New York State programs based upon what they think is right, and I feel very strongly about that.
I think perceptions are reality, and it's unfortunate that you perceive my response to say what I don't think that I said. What I'm saying is, if we have every state in the United States that wants to establish their own system of accreditation, it dismantles the organized system of accreditation and interactive issues that are very important for all of graduate medical education. It's not just important in New York State or Texas. Why should all of these be different? We're dealing with the same issue.
Well, we'll give these two a rest, and let's go to a question from the floor. The gentleman at microphone number 1 has been waiting patiently.
My name is Michael Laufer. I'm a fellow at Stanford University in emergency medicine, having completed my residency at a county hospital in Los Angeles last year. I'm also the chairperson of the AMA Resident Physician Section, and as such would like to welcome you and the comments that we've heard from the phone, as well as people here in this audience. Rather than debating the issue, I'd like to focus it a little bit historically and then ask my final question.
We really don't have a lot of time. If you have a question, please
understand.
ask it. We don't have time for an historical perspective.
I understand. The question is related to the fact that the public has a problem with our working when we're tired. And they have a problem to the extent that they are asking us now, how long have we been up? Are we capable of caring for them? And these are the sick patients, not the ones who are well and only care theoretically, but the ones who are sick and want not only someone to be there, but someone who can take care of them. We're told by the ACGME and RRCs that regulation is not the best way to do or to solve the problem, and that they wanted a chance to deal with it. And in fact, they have had this amount of time now for the year to deal with it. And some specialties have been inadequate in their response. Given that, and given that the public still cares, I don't think that we can take Dr. Deaconess's study, given our own common sense, and agree that a problem doesn't exist. And given what Dr. Dockery says, essentially that we've done everything we can, and that we should be heartened by the process, as opposed to hardened by the process, I wonder what we have left other than regulation. And that's my question.
Anyone care to handle that one? Dr. Deaconson?
Name's Deaconson, not Deaconess, but that's okay. You stated two questions. You said the patients ask, how long have we been up and are we capable of caring for them? I don't know if you meant to imply that the two are uniquely dependent upon each other. That's something that we're trying to dissuade the public from believing. That is, that every individual has the same capability of withstanding sleep deprivation, and therefore an assigned number of hours applies to all and infers upon their capability to take care of patients. I think that's a mistake, and I think that is also a reflection of our inadequate body of knowledge on physician subjects and sleep deprivation. I think that the problem's much deeper and stems from an unhappiness among many resident physicians who, in addition to sleep deprivation, have many other stresses, many of which may be more important than sleep deprivation in itself, in their unhappiness with their work schedules. And secondly, our paper doesn't say that a problem doesn't exist. In fact, we acknowledge that it does. We simply say that we didn't find a sleep deprivation-induced deficit after 24 hours. in surgical residence.
We have Dr. Mark Leck waiting on the telephone lines. Dr. Leck, what's your question?
Jesus.
Dr. Leck, what's your question? Yes, Dr. Mark Leck, can you hear us? We're waiting eagerly for your question. And he's trying.
Hello.
I'm
calling from an airphone at 35,000 feet, somewhere between Boston and Chicago. I had hoped to be present at this session, but my department chairman forbade me from coming. Therefore, because of my own fear of retribution, I would prefer to remain relatively anonymous. I have a comment and a question for Dr. Condon.
Dr. Condon wasn't able to be with us
search
today.
of the academic literature on the subject of sleep deprivation produces, in addition to the references in your article, a rash of articles about sleep deprivation as a form of torture in the Middle East and Latin America. I imagine that the secret police feel a bit silly now that your study is out, however. In your paper in JAMA, you took a group of chronically sleep-deprived surgical residents and divided them into two groups, those who were also acutely sleep-deprived and those who were not. As you stated, there are no well-rested surgical residents in your program. You showed that the residents who were only chronically sleep-deprived did just as poorly as those residents who were also acutely sleep-deprived on such tests as the Purdue pegboard and the trail-making test, which is sort of a fancy connect-the-dots game. You presented several pages of statistical analysis and finally were able to link your findings to actual clinical medicine, although by your own admission, only through implication. My question is, what evidence do you have, sir, if any, that the findings of your study have any direct clinical relevance whatsoever in the day-to-day and night-to-night practice of medicine by residents or any other physicians?
Well, Dr. Leck, Dr. Condon isn't with us today, but Timothy Dickinson, who was also an author of the study, is here, and we're going to give your question to him.
Okay, I'll answer the first part, and because he's calling from an airphone, we up here could not hear him well, so maybe if one of the audience who heard could stand up and in a minute reiterate one of his questions. I think I heard him ascribe the hours of residency to torture or something like that. Is that right?
Sleep deprivation is used as a means of torture in Middle Eastern countries, I believe, was the particular quote.
I think it is. That is true. So is giving of medicine at one point. But we all give medicines, and we all are sleep deprived when our patient care necessitates it. I think this is a good example of the fact that we have little fund of knowledge on the subject. And I am a little bit disappointed in his and other members of the medical community's response to our study. When the study produces results that are unexpected, it produces a challenge to the medical community or scientific community to reproduce the experimental method and either validate or invalidate the results. And this is just an example of an individual who is willing to propagate the histrionics involved with this sensitive issue and neglecting the science of it.
Let's take, you've been waiting patiently at microphone number 3. Let's take a question from the floor.
Thank you. I'm Dr. Thomas Cooper from Irvine, California. I guess given the high cost of medical education now, and also given the very high cost of living in most of the major cities where the residency programs are located, there's a strong temptation on the part of some residents to moonlight, or I guess an economic necessity of others to moonlight. We've also heard some people say that why should we give residents time off from the teaching programs, and they'll just go out and moonlight and then spend the same hours. So why should we do that? Can any of the panel make comments on, I suppose, the issue of moonlighting and residency work hours?
I think that a major issue which has not been addressed is the whole issue of debt in terms of going to medical school. It's getting to be so that you have to really be a millionaire before you can even go. I think that we've got to address the issue. The issue is not moonlighting. The issue really is how you're going to pay off all of that money. And I think that something is going to have to be done about that very quickly. That's a major issue that needs to be addressed. And that issue is how are people going to be able to go to medical school and pay for it legitimately?
Elizabeth, in New York, has the issue of moonlighting been considered in those regulations of work hours?
It is, and just for clarification, it is effectively prohibited by the regulations. In other words, any work service you do in another institution providing health care counts toward the 80 hours and the 24 hours. So it's going to be extraordinarily difficult for residents to gain any financial benefit from moonlighting, because really those hours are going to be terribly limited. In addition, as we go to moving everyone to 80, which is really the PGY1s in most cases, down to 80, in some cases we are moving the PGY2s and 3s up to 80 in order to take up some of the slack in some of the programs, which means that 2s and 3s who might have had some free time because their regular work schedules did not exceed the 80 hours will now be working 80 hours at their home institution. It is of a major concern, I think, to those whom we are training right now.
Well, it's apparent that throughout the country, academic health centers play a critical role in medical research, education, and highly sophisticated patient care. It's in this environment where the changes in the work hour regulations will have the strongest impact.
It is at the nation's academic health centers where the majority of health professionals receive their education. Although these teaching hospitals make up only 6% of acute care facilities, they provide 43% of all care and 52% of uncompensated care. It is in this setting that the demands of education, basic research, and patient care vie for limited resources.
If the reduction in hours is too stringent, the actual exposure of the residents to the surgical procedures and to the follow-up and continuity of care could be compromised. So that's one concern. Another concern that I have, perhaps on a more pragmatic or financial basis, is that to the extent that residents are less available for patient care as a part of their educational process and in addition to some service responsibilities, then we have to either get more residents or more non-MD personnel to make sure that the patient needs are met. That could very well result in significantly increased cost to the community hospital at a time when the revenue through the reduction in the Medicare allocations is going down rather sharply.
A study was recently commissioned to assess the impact of the new regulations in New York.
Essentially what we did was do a statewide survey of all teaching hospitals to find out the number of hours residents currently work by program specialty and by hospital, and then examine the fiscal implications of restricting working hours to 80 hours per week. We came up with a statewide estimate of anywhere from $80 to $120 million just for that component of it, which would mean that hospitals would have to hire essentially about 1,000 new individuals to do the work that residents are currently doing.
With the reduction of resident work hours comes an increase in costs and the need for new ways of hospital financing.
Well, at least in the case of New York, the way that it's going to be financed is that the cost of this is going to be shared by all third-party payers. And really, since the cost is so substantial, the state has decided to spread it across Medicaid, Blue Cross, and commercial payers. Really, for most of the hospitals that we surveyed, in order for them to voluntarily implement these regulations, it would be quite expensive. And for them to find additional sources of revenue would be quite difficult without having some type of an agreement with third-party payers that they would help finance this.
We are looking at several sources. One, of course, is for the private attending physician who functions as a supervisor for the resident to be able to bill under, say, Medicare Part B for his services, providing he meets certain criteria in terms of supervision of the resident. Secondly, we are significantly increasing our fundraising efforts to develop a separate source of revenue from philanthropy in the Washington, D.C. community to try to endow some of these resident and fellow physicians.
The only option that is going to cost less or will not cost more is if you do away with the house staff program altogether. And I think that some hospitals may very well end up doing this. Some hospitals who are already creaking under training costs, it will be mainly community hospitals, and they're just simply going to say, well, we're going to get out of this business.
Although the proposed State of New York budget for the coming fiscal year allegedly includes money for the implementation of these regulations, the same budget proposes a reduction in payments to hospitals of an equal amount for other areas. That is, a net zero increase in dollars. That means to us that the regulations will come to us without the dollars necessary to pay for them.
The death of Libby Zion in 1984 led to many reforms in resident education. However, there is much work yet to be done, and finding the right balance between the needs of the residents, the patients, and the hospitals will take time.
The surgical specialties accredit programs based on their understanding that residents will get a certain level of experience on a continuous basis. If you remove beds from resident coverage, you've removed patients from that experience. And it's very likely, in my judgment, that as you remove patients from the experience, the residency review committees will say, you now no longer are justified to have the number of residents you presently have. We're going to reduce your residents by the number of beds that you've reduced. Hence, the more beds you take out, the fewer residents you have until you've finally reductio ad absurdum, reduce the program to zero.
So I don't think you're going to have a revolution. I think everybody has taken a look at it, and I think a fair number of people have found, well, look, we got no problem, we have no problem, and we don't have to enact rules and regulations. And I don't think there's a big move for these things to spread through legislatures. I think that they are sort of waiting to see what the outcome of all these rules and regulations and the cost in New York is going to be. And there's every evidence, every reason to believe that in New York City, at least, when these things are implemented this coming July, there is no good way to pay for them.
As we approach the last segment of our program, I would request that the questioners keep their questions as succinct as possible, and I would make the same request of the answerers, so we can try to get everyone in. But I'd like to start with one question that I think is fundamental that we have not asked yet. Dr. Dockery, if there is a fatigue-induced mistake, who is liable?
Everyone.
Legally liable?
Legally and morally. It, of course, depends on the situation in which the resident is working, whether it's a public institution, whether it's affiliated with an academic health center, whether it's a community-based program. There would certainly be shared responsibility depending upon the participants and the contributors to that adverse impact. If there's a mistake that has no serious outcome, that does not adversely affect a patient's life or their health, probably nothing would happen except for some imposed constraints that would help to prevent that from happening again in the future.
Tim, you're eager to jump in?
I just simply wanted to add from the point of a researcher, until we have a body of knowledge that states definitively within the confines of an average call schedule, does a resident become impaired due to his sleep deprivation. Until that's established, I think we should refrain from acknowledging that we are impaired. Otherwise, if you're conscientious, you are also acknowledging a liability for any mistakes you were made while you are self-acknowledged and sleep deprived and impaired.
My response was based upon the fact that if an adverse event happens, then the burden of proof on you is the fact that it's not because you'd worked 23 hours or 25 hours or 26 hours if your call schedule was 24.
Let's take a question from microphone number 2.
Hello, I'm Beth Mallow, a neurology resident from Boston, and my question is for Dr. Bell. I hope you'll touch on the effects of sleep deprivation on the more human side of medicine, the talking to patients. Everyone in this room knows how it feels to be up all night at the end of a 36-hour shift, just sort of avoid the patients, get out of the hospital, not talk to patients, answer their questions, talk with the families, things that we went into medicine for. And I think that this is what the patients want as well. What can we do?
Well, I think one of the things that came out of the work that we did over that 19 months was to recognize that patients were not the only issue here, that residents were the issue, and the residents' health and how they looked at patients was the issue. And I think that if we come up with reasonable schedules, the fun part of being a doctor will get back into things. So I think that one of the big problems is that people are overworked and they can't possibly feel for people when they are that way.
Microphone number 1.
Yes, I'm John Lieberman, University of Tennessee, Knoxville, general surgery resident. I'd like to make a point that perhaps someone on the panel would comment on. I know that after I work 24 hours, I am not at my best. And the public knows that, and I don't believe that I am any different than any other general surgery resident in this country. And I believe that the American public trusts medicine less. I believe that medicine loses credibility with the American public when the American public is told that residents can function effectively after 24 hours. I believe the American public goes by common sense, and studies may point in the other direction, but the common person is going to look at this situation and analyze it, and the country is going to make decisions outside of medicine, and I think medicine is going to lose control of the decision-making process.
Dr. Dockery?
I share what you say. I know when I'm tired. I cannot comment on the study in terms of the way it was evaluated. I trust that it was done in a scientific manner. I don't know of a system, however, that can impose shift work on medicine and can impose shift work on physicians. I think that we need to be cognizant of what's happening to our colleagues. I think the faculty and the residents that are above that individual level of resident performer needs to be aware and alert to when that individual should receive rest, and that we should not have people who are working that are so fatigued that they cannot do the best job that they need to do for themselves and also for their patients.
Tim?
I'm not trying to be in opposition to reform. One interesting finding that we picked up in our study is that less than half of the residents, when they underwent their psychometric testing every morning and concurrently filled out self-assessments of fatigue and motivation, less than half of the participants had a correlation between their own feeling of fatigue and how they eventually did on the test. So when you say after 24 hours you don't feel like your best, perhaps you aren't, but perhaps others in your program are, even though they also feel badly because of their fatigue. And I just say this to warn against making a solid, inflexible definition based on your own anecdotal experience that you wish to apply to all, because it may be too restrictive.
Thanks, Tim. Perhaps foolishly, we are going to try to go back to the phones. We have a caller from Colorado Springs. What's your question, please? Hello? Colorado Springs, can you hear us? Okay, I don't think we're going to try that again.
Hello?
Oh, there you are, just when we were giving up.
Yes, I have a question for Dr. Dickinson. I have read his study, and I've also read the letters to the editors published in JAMA, and I've seen that he has a lot of critics and not very many supporters. I was curious if any of his critics or any other people in the medical scientific community have tried to repeat Dr. Dickinson's study to try and to substantiate or repudiate his findings. And if they haven't, I was wondering why the critics are they basically putting their criticism on anecdotal findings and conjecture.
I think I got that, Tim, if you didn't.
Why don't you repeat it then?
I think that at least part of the question was, has your study been repeated by any other group in the scientific community?
I wish it had. It was a very exhaustive study. I personally delivered the test for the sake of consistency every morning at 6 a.m. for 3 months and graded every paper and managed all the data myself. So it was very exhaustive, and I think that is going to prohibit a lot of people from wanting to repeat it. However, there is a group in internal medicine from San Francisco General who has communicated with me stating that they would like to repeat our experimental method to see if they get the same results. And regardless of how their results turn out, I applaud their scientific objectivity and wish them the luck in doing so.
Is there any chance that your results were skewed because of your own sleep deprivation and doing all this work?
Yeah, touche. During this time, I was on a research rotation.
That's good to know.
Did not take any overnight call.
That's good to know. Before we take the next question, I'd just like to remind everyone here that this teleconference on work hour regulations is one of the ways the AMA's resident physician section is serving its members. The AMA RPS serves as a national forum for the discussion of issues relevant to residents and is a vehicle that brings those issues to the AMA's House of Delegates. If you'd like to learn more about the AMA RPS, just call this number, 312-645-4751, or you can write to the American Medical Association Department of Resident Physician Services, and that's 535 North Dearborn Street, Chicago, Illinois, 60610. Now, let's go back to our microphones. I believe we were at microphone number 3. Was that correct?
It's fine. Thank you. My name's Nick Dewan. I'm from Los Angeles, California. I'm a resident at the USC Medical Center. Question I have is, we talk about making these changes, but the bottom line seems to be money. I'm wondering if anybody's come out with a plan how we're going to raise $120 million in New York or $100 million in California or any other state. What's the plan?
Let's ask Elizabeth. You're trying to do it right now.
The check is in the mail, actually. No, actually, to be fair to the State Health Department, they have found the money in their budget, and it extrapolates across the system to $226 million is what the price tag is for the set of recommendations that begin July 1st in New York. What they have done is they have found their fair share, and they have taken the Medicare piece, which would not have been paid for because, as you heard Ken Thorpe say, Medicare is, while I'm sure they're very supportive of change, they don't pay for much they support these days. And they have taken that 40% and extrapolated it across the system so that Blue Cross and other payers are paying perhaps more than what they perceive to be their fair share. The number 226 million, about 65 million of it is for the ancillary support personnel, which we have none of at the moment, the phlebotomists, IV teams, housekeepers, messengers, transporters. About $80 million of it is to replace the lost hours due to the working hour restrictions, and that is with nurse practitioners, PAs, and attendings, if we can find them. And the remainder is for the added enhanced supervision requirements. 226 million, we extrapolated the other day over the next 10 years. In 10 years, it will have cost the New York system $3.1 billion, and in 15 years, it will have cost the New York system $5.7 billion.
Just follow-up question. How many hours, would that be an 80-hour guideline, or how many hours would that be for physicians in training?
The money was calculated on a resident working the maximum 80 hours and having a 24-hour cap, with the exception of the surgical programs for which there have been some changes in the regulation and there is a different set of assumptions.
Let's go to microphone number 1, please.
Yes, my name is Bob Walker from New York. This is a question for Dr. Deaconson. As you know, the federal government, for whatever reasons, very tightly regulates another professional group. That's airline pilots. They are only limited to flying a certain number of hours per day. Obviously, the federal government feels that with sleep deprivation, there is a loss of manual dexterity, and there is a loss of clear thought, and these people should not be flying airplanes. My question to you, sir, in spite of all the number crunching you've done, is why are doctors different?
I don't know that doctors are different. We're both motivated professionals. I think the tasks that we do are different in the middle of the night. I would hope so. Will Swebb, who is a sleep physiologist in Gainesville, Florida at the university, has been one of our informal consultants during our project, and he will advocate that sleep deprivation impairments are task related. Picture yourself or picture anyone in the room getting up at night to read a book at 2 in the morning, probably fall back to sleep. But if a 747 crashed a mile away, chances are he'd be wide awake. And I would like to think that part of the reform would be to reduce the monotonous tasks, the repetitive tasks, and monitoring tasks that can be done with ancillary help on a shift mentality, or with mechanized technology, such that the physician himself won't have to be up at night doing things that are monotonous. I'm not saying that an airline's pilot's job is monotonous, but nevertheless he does do something that is hopefully calm and monotonous.
Elizabeth?
Yeah, I just want to follow up on my own answer because I left something out, which is we have found the $226 million. One of the problems is that we are going to put that $226 million on a very leaky foundation. We are hemorrhaging all over the place hospitals. 2/3 of the hospitals in New York are already losing in the aggregate hundreds of millions of dollars. And one of the concerns is that we found new money for new requirements, but we have not shored up the ship, which is sort of sinking.
We're getting really tight on time, so microphone number 2, if you could make your question very pithy.
Thank you. I'll stay as pithy as I can. My name is Mike Williams. I'm from Indianapolis. I represent the American Academy of Neurology. Since the rest of the nation is embarked on a course of having the ACGME requirements enforced, I have a question about the mechanism of this. My own program went through a site visit this year, which was the first site visit in 5 years. Will we have to wait 5 years before the RRC requirements for call are enforced? And the second question has to deal with determining the average number of calls. Will this average all residents?
Really running short of time. We probably only have time for the first part of the question.
Fine, thank you.
Dr. Doctor, you want to handle that?
Just to say, the residency review committees are continued to be monitored, and they have a delegated authority for a specific period of time. Those are the maximum period of time which they were reviewed are 3 years, and they were reviewed for as little as 12 months. So I think there would be a correction process that would fall outside the 5-year plan that you've described.
Thanks very much for all of your questions. We are out of time. While there's been obviously much rhetoric surrounding the issue of resident work hours, a new reality is beginning to take shape, however slowly. Certainly there needs to be a balance between the needs of the patient, the hospital, and the resident. Discussions like today's will help find answers to some of those questions. I would like to thank everyone on the panel, and of course everyone in our audience who participated with questions, and certainly all of those who called in on the phone. Thanks, as such as it was. And thanks to everyone who joined us at hospitals all around the country, for it is there at your hospital where the rhetoric will indeed become reality. I'm Joan Esposito. Thanks very much for